Then next slide is about TB screening and OPD. Yes, you can see the period we are doing. We are doing July, September, and also October, December. But you can look at the total OPD for the July, for example. Let us take July, September. Total OPD attendance was 214,564 in the district. But out of that number, the ones that were screened were 100,000 and yet the policy said everyone that reaches OPD must be screened for TB, HIV, leprosy. I think for most of you who are using the new version of the OPD register, column 14, after TB there is also leprosy. They have also included it in the register. So meaning everyone is supposed to be screened for this. The best performing district, there are some districts who are doing well with this. The total OPD attendance may even equal to the number of people that were screened. But what happens is that when you go to that column, you also see the nose. Screened for TB, no. And of course, automatically when the data person is collecting the data, we just say you did not screen for TB. Some facilities have gone ahead to make the screening stamp. There is a stamp I posted on the TB platform for Hima Health Center 3. Yes, so that after the clinician has screened, puts the stamp. And the stamp has all the screening indicators. Any cough, regardless of duration, fever, night sweats, and so forth. Because it's no longer the other cough of weeks. They say every cough, regardless of duration, is the suspect for TB. Being suspicious does not mean you are biased or you also doubt yourself. When we suspect more, we are likely to also get a few that could be having this disease. But the challenge is that we're always thinking of the other coronavirus, and the rest. And when you go to the register, that's what we find out. But collecting the sample has always been a problem in most of our facilities. So we say, when you screening all the class, at least we need 100%. But you see we are 61%, that is September, then October, December, we have 68. No, we increased it from the previous, but the overall percentage. The overall percentage is also not well promising. You can see 65%. At least we are supposed to be above 80. So we request facilities that are screen and also document, so that when we are reporting the 033, that weekly report, this is what brings this. We should see everyone screened for TB. And I know most of you screen, but the problem is the person handling the register. OPD register. Let's teach them, if they are recording officer, maybe students at your facility. Tell them what they are supposed to get when they being asked about the screening for TB, HIV, and also leprosy. We need to strive and reach 100%. Next is about facility level screening. Okay. We have seen the percentage. Let's look at now. How many people we are presuming? You can see about the presumption. Only 3, for example, July, September, 3,507 we are presuming to be for TB. TB presumption means TB suspects. The ones who are suspected to be having what? TB. And yet the policy says 10% of the OPD attendees should be presumptive. That's why you have 3%. You get so meaning though we did not spread, we also presume less. But if we spread well, if we had like 100% or 80%, I expect we would be having more presumptives. We would be having many presumptives in the register, and these people, you never know, we have but you're going to see also the and you can see the ones we organized with TP, they are 167. That is for July, September 2025. Did you want to also come in?
My point there is, in facilities, we are not presuming. The rule says you should presume at least 10% of those that are screened. Look at when you presume 10%, you see, presume 160. That means if you presume up 10%, we should have had enough of it. So you are leaving the TBs in the community because you are not presuming up to around 10%. So please presume. It says we have a lot of TB that is there, it has not presumed and therefore not tested. So it is still with us, but we think it's not there because we are not presuming enough. That's what this means.
Thank you so much. And it is the same to October, December, it is still the same. We also still presumed less, and we still, though the number increased from 167 to 174, but we still think, just like I said, if we presumed many, we would be also having so many cases. And remember the national policy, the target is that by 2030, we should have 0 new TB and HIV cases. So if we are struggling for this, we need to suspect highly. Our suspicion index has to increase. Even when you are in your consultation, you see much of this screening part is done by the clinician of the day. Whether you are a doctor, maybe you are a clinical officer, or you are a nurse, but you are the one lacking your plans. Let's put in more emphasis on screening. So the overall percentage you can see in total, the total pediatrics, you can see the total for the two quarters, and the overall percentage of the screening rate you have 65%, but also the presumption rate is down up to 2%. And with October, December, we did back, the presumption rate was 1%. Imagine. So let's really put in more effort in screening and also proper documentation. And go to the next. So, though we are not doing well with screening, documentation, and rest, not all facilities are doing bad. You get? Yes, we have facilities that are doing very well. We say thank you to this facility. You can see we have some facilities with over 100%. Those are for the quarters that we pick. You can see Mukati, Campus is doing well with this. Stripes, some of them are private. We have Give a God. Refugees. We have Kasanga PHC. This is also doing well with the screening at OPD. Saluti, Munguni Health Center 2, Muhoja Health Center 3, Kanamba, Nyabirongo, Prison Health Center 3, then Kichwamba. These people are really struggling, but the only trick, I know most of you are screening. The only trick they are doing is documentation. I know even the rest of you are screening in consultation, but the challenge is about documentation. They are not indicating in the register that people were screening. So let's screen and also document. So the work. So these facilities really needs more effort. I think we also need to read some names of them. About Rwenzori, we need a corrective action. I think Rwenzori for this quarter they did well. We went there to look at this data. We start with the facility. We realized that the clinicians are ever screening, but the OPD register is with some students outside. And maybe report these officers, and they are not indicating in the register that people were screening. So we start with them and we harmonize. I think the next quarter we're going to do very well. So we have Buhalita Health Center 3, we have Nyabwamba, Itolu Health Center, Katulu Health Center 3, Health Center 2, we have Afia, Bethel Medical Clinic, Buhatiro, Buhunga Muyara, Bumbahat, Bumbeka Baptist. I haven't reached there by now, that's Bumbeka. Ebugaretis, Atoke, Ikorongo, Ikyo Health Center, Kilembe Health Center 2, Kilembe Mine is the hospital, yes. Kilembe Mine is the hospital, I think we sent there a technical assistant, you know what happened. And there are a lot of issues, I think, that we harmonize. And we think even these other facilities can come to green. This is very simple. Very simple, just like I told you, screen document in the OPD register. And when you also submit it the 033P, that's what the tariff is. Even when the register is saying you screen, but when you are quoting the 033, the weekly, you still leave that space empty. And others even put 00. Someone will say, the total PD attendance we had 100, but we screened the 0 for what? For TB. See, it is not right. So let's correct all those, and we all come to green. Next. TB case, now case notification. Now, after getting the clans, TB clans, TB patients, now what do we do? About notification, we are reviewing the whole year. Yes, we are reviewing the July, from July, September, October, December. And you can see the total new and the relapse cases. When you talk of new and relapse, we are meaning the cases of TB that were caught, and these people had never gotten TB. The first cases, people were diagnosed with TB for the first time. Then when you talk of relapse, we are meaning this patient who was initially initiated on treatment, finished the treatment, declared maybe cured or maybe completed, and afterwards, after some period, and then contracts the TB. Those are the relapse because we still give them treatment. So the total for July, September, we had 296, and we are glad that all of them we are started in treatment. That was so nice. We got 296 for July. Unlike, let's compare with October, December. Unlike October, December, where we had 244, but we initiated 243, meaning there is one person that got lost, and that is a big burden. A single case can pollute the whole community when it comes to TB. So they would not do well for October, December. Then if you go back to July, September, out of the cases that were initiated on treatment, the 296, the one that accessed gene expert were 225. I know someone is going to think of others were PCDs. No. Currently, the new policy is gene expert access for all, regardless of the classification. Both the PCDs and the PBCs, all of them should access gene expert. And the thing is simple. We have our gene expert machines, we have so many. We have Guerra as a site, we have Kagano, we have Mount St. Mary's, and we have the SAP. Like Rukok has another molecular test machine. It's called a tuner. It also does. And even the KMC, by the way, KMC also has TB lab, it's also tuner. So meaning, all our clients should access gene expert. I talk about some let all of them access the gene expert. He has moved to the first go back to Mr. Costa. There's something I need to bring. Now, we would rather go to the previous slide because there's something I'm much interested in. So you go ahead. Yeah? You can look at now the percentages in terms of access to gene expert. We fairly did well in July, September with 76%, but when it came to October, December, we dropped down to 66%, and this was not good. So the other one is about the classification. That one we can leave. Can go to the next. Next. So now TB classification by proportions, you can see the PCDs were taking 32%. These are the clinically recognized TB cases. Then the preliminary bacteriologically confirmed, the ones where you have done the molecular test and the TB is really confirmed. That was 65%. Then extra, that is the TB outside the lung. The TB can affect the bones, affect maybe the abdomen, any other part apart from that. So the extra pulmonary tuberculosis will have 3%. Then this is another good slide. TB treatment success rates and cure rates in the district. So this one we put the whole year up to December, January up to December, and you can see for the total reported for January to March, let us sample only January to March, we had 292, and out of the 292, the PBCs, the one who were confirmed by molecular tests, they were 180. Then those who cured, actually we expect the PBCs to end up with the cure. But you can see there is a difference. Out of 180, 167 cured, we are thinking that maybe others died, and maybe others were left to follow up. And when you go ahead, you can see now they completed. The ones that complete, we expect them to be only the PCDs. Actually, what our request is, never make a PBC complete. Let this person cure. Because the reason why others put them under completion, they don't do the evaluation, the progress investigation, the follow-up smears. So if you have a PBC, let it end as a PBC by doing the evaluation smears so that you can declare the person cured, not being pushed to what? To complete it. So we expect the cure rate to be 100%. Then you can see now, but you can see only 2 were lost to follow. That is the Jan to March, and the 10 of them died. So we still have people who died because of TB. And a case that is regarded having died of TB is that case that dies immediately after TB treatment. Actually, when you take the TB drugs now and you go, they knock you there, and you get an accident and die, we still categorize you under there. So whoever dies during the course of treatment, that's what we are urging with the MOH. People are dying of HIV, while the rest, but as long as they are still taking the treatment, they are categorized down there. But after treatment, don't put that person there. You get that point. Whoever dies after treatment, that was because of the condition that has taken him or her. So that's why you can see the cure rate we are at 92%. But if you can fall down, you will see that we are reducing because in the June it was 91 from 93. Then if you drop down from 91 to 90 to 82. Then when the troubles came in, those issues, and what happened, again they drop it down. So we think we request the facilities. Though the troubles came in, let's leave the trouble issues and we concentrate as health workers, government health workers, and we make sure we still update our registers very well. Otherwise the curve is still moving down. So we expect the Jan March to increase and we go back to our 9.5. The treatment success rate, the TSR, that one at least we are doing well, though still the curve is so it was 96, also the curve is not very moving well. Then the percentage of death, 3%, the 10 years, 0 at least. And the evaluation, it is only July, September that we dropped from 100 to 98. That is October, December. So let's really evaluate our class, smears and the rest, and make sure we really improve here.
So that is the camp we have been almost
Discussing. Tested after intensive phase. You can see January, March 74, April, June 71, July, September 67, October, December 48. You see, here we are not doing well. The curve is not promising. Kindly, let's step in as health workers and we'll make sure we improve this. These are best performing facilities. You know, the way we expected our data wanted to show the performing facilities and also the other ones. So that maybe we can also be asking for how we are doing well. So in terms of Katadoba, Katunguru, Kinyamaseke, Kishwamba, at least for them, the PBCs, aims of PBCs, they always do the evaluation of the spheres and they declare them as having.
sure. So these people were being all the maths
that we were evaluating, you can say 100%. So kindly, we expect such a slide for all of the facilities. And if you wanted to say Resorora, it can even take yourself, and also take your brother, your sister, and any other person. We had our patient, our health work from Kaki, who contracted it from work. So to get the money collecting, you also put yourself at risk because it does not segregate. Next slide, Mr. Costa. Facilities that need support. So these are the facilities, you can see them. I cannot read all of them.
but especially this one
That the red is road. And let's see how we can improve. We are there to support you. Even your fellow worker from the neighboring facility can really give you support. So that